Uh, Welcome again. The next keynote session is by Dr. Arvind Srinivasan, CMO of Arvind Eye Hospitals, Chennai. Dr. Arvind, just 1 minute. Dr. Arvind has pursued his MBA with specialization in strategy from University of Michigan, Ann Arbor, USA in 2000, and then he took over as an administrator of Arvind Eye Care System. The Arvind Eye model is a very popular case study and is part of MBA curriculum in IIMA. I would like to invite Professor Rajesh Chandwani to speak a few words for him. Thank you.
Thank you, Priya. So while Dr. Arvind is on the way from airport, he has already landed and he's expected any minute here. So we had planned this session in such a way that first of all many of you would have read Arvind Eye case in detail, either in MBA or in hospital administration or in popular media like press or magazines. So one of the important things about Arvind Eye is being 5% of the ophthalmology personnel in that organization, it caters to more than 15% of the ophthalmology services in India. So it's a very efficient model. The cases which are written in IIM Ahmedabad itself has written 3 cases on Arvind Eye, and there are multiple cases on Arvind Eye which explore this aspect of how Arvind Eye actually is able to perform this type of scale with lesser number of doctors and paramedics. So the focus of those cases are largely on efficiency. So if we want to study Arvind Eye case, we need to know about how it operates. What are the systems which are in place there? Unfortunately, we can't go to Arvind Eye, but what we can do is we can watch a 15 minutes video about how the things happen in Arvind Eye, so that when he comes, you have a background of the organization itself. The focus of Dr. Arvind's talk will be on why Arvind Eye does this. What is the purpose of these organizations? So first we will take a look at the video. We will try to understand how things are done, and then from Dr. Arvind himself, we will listen to not how, but why and the purpose of the organization. Okay. So let us start the video, and by the time I hope he will be back.
Worldwide, 285 million people are blind or visually impaired. 80% of that blindness is avoidable. A simple operation can restore sight. But for many, the cost of treatment is simply too high. Here in South India, in a city called Madurai, Arvind has been working to turn those economics around. When people walk into an Arvind Eye hospital, they have a choice, whether to pay for treatment or to receive it for free.
The vision and the mission of Arvind is to eliminate needless blindness. Anybody can walk in, whether he is a rich or a poor, educated or uneducated. Anybody will be treated in the same way with dignity.
No one is turned away, and patients do not have to wait for treatment.
Arvind does not work on an appointment system. Whoever comes across gets seen on that day. We never make a patient wait or come again for things that can be done on the same day.
Collectively, Aurovind's network of hospitals see over 12,000 patients and perform 1,500 operations each day. The quality of treatment is the same for both paying and free patients. In this model, revenue from each paying patient supports treatment for 2 free surgeries. Aurovind does not depend on donations or government support. Patient income funds all its growth and expansion. Their mission is to make the highest quality eye care available to anyone who needs it, rich or poor. Today, a streamlined workflow, rigorous systems, and a mindset of frugality enable Aurovind to perform over 200,000 free surgeries each year.
It should be affordable to everyone. Everyone who has eyes must have a sight.
When Aurovind first opened its doors and offered free service, it discovered another barrier to access. Many patients lived in rural settings, far away from a hospital. They could not afford the cost of the journey. Since these patients could not come to Aurovind, Aurovind went to them. A series of eye camps were launched in rural areas.
The camp is basically an outreach program. So we come to the places which are not easily accessible. We do a screening for them, and the patients that require surgery, we'll take them back to the base hospital, do a surgery free of cost, and bring them back here.
This woman has a cataract in her left eye.
இல்லை பாருங்கம்மா நம்ம புற ரொம்ப இருக்கு சரியா அதனால பின்னாடி நரம்பு எப்படி இருக்குன்னு இப்போ சொல்ல முடியாது
காவட்ட போனாது காய் கஷ்டப்பட்டு போனாது அது நறுக்க வேலை செஞ்சால் தானே வாங்குவாங்க ஒரு காட்டுக்கே போனாலும் திட்டு போட்டு விட்டுருவோம் அதே அப்புறம் கொஞ்சம் மங்களம் தெரியுதுங்களா இருட்டாகிட்டா கொஞ்சம் தடுமாறிக்கிட்டு விழுந்துட்டு என்ன பண்ணுறதுன்னு வீட்டுக்கு வந்துடும்
சரியா அப்போ அந்த கண்ணு பண்ண மாதிரியெல்லாம் இந்த கண்ணு இப்போ அந்த கண்ணு இப்போ கொஞ்சம் தான் இருந்தது இந்த கண்ணு இப்போ ஜாஸ்தி இருக்கு
She is one of 200 people from this village whom Aurovind will bus back to the main hospital for surgery, where they will receive food, lodging, treatment, return transport, and follow-up care completely free of charge.
காசு வேணுங்கிற கல்வி கட்டி படிச்சு அதனால இலவசமாக பண்ணும்போது அது வழியாக
Today, Aurovind sees over 3 million people every year, but it started from very humble beginnings. The driving force behind it was Dr. Govindappa Venkataswamy, an ophthalmologist fueled by a compassionate vision.
He set out to cure blindness, not just in his own town or the state of Tamil Nadu, but for the entire world.
Here was a man who was able to look beyond the national boundaries, the religious boundaries, and look at every person and said, why should anyone be blind in this world?
In his early 30s, Dr. V, as he was known, contracted rheumatoid arthritis, a lifelong condition that left his fingers permanently crippled.
That experience gave him a feeling of a patient. Fear, depression, anxiety, pain, looking for somebody with a smile, longing for somebody with a smile. All those things he experienced.
Despite this illness, Dr. V trained as an eye surgeon and went on to personally perform over 100,000 operations. At the age of 58, Dr. V retired as a government ophthalmologist. With his brothers and sisters, he opened an 11-bed eye clinic called Aurovind to continue his work. They followed 3 simple principles. We won't turn anyone away. We won't compromise on quality. We must be self-reliant.
Dr. V had this phenomenal vision. He was able to think 20, 30, 40 years in advance when he had a 11-bedded clinic.
India is a country of over 1 billion people with less than 20,000 ophthalmologists. Dr. V knew the scale of the problem demanded a solution of appropriate magnitude. It called for the development of highly efficient systems. 40 years later, his 11-bed eye clinic is now the largest provider of eye care in the world.
ఎంత కన్నా ఆపరేషన్ చేయి.
Optimization of workflow, particularly in the operating theater, has revolutionized the number of surgeries performed.
One of the ways which continues to work very well is for each surgeon to have 2 surgical tables. The surgeon sits in the center and is able to operate upon one patient, whereas the second patient gets prepared by a support team.
When one cataract surgery is complete, the surgeon just moves across to the next cataract table. The time between surgeries is greatly reduced, and the surgeon goes from performing 1 surgery per hour to about 7 or 8 per hour.
This way, a typical surgeon at Aravind is able to perform between 1,500 and 2,000 operations a year, against a national average of 400. In 2015, Aravind treated close to 4 million patients and performed over 400,000 operations at a fraction of what it would cost in other countries. And yet, their clinical outcomes meet or exceed those of hospitals in the West.
Good girl.
That number keeps the organization financially sustainable, keeps the individual productive, and we are able to reach more in the community and provide sight.
With her operation complete, this woman will rest in the hospital for a few days.
உட்கார்ந்து படுத்துக்கோங்க பாட்டிமா, சரிங்களா? ரெஸ்ட் எடுங்க. மருந்துலாம் ஊத்துறாங்களா?
Today, a standard cataract operation involves removing the clouded lens and inserting a synthetic intraocular lens, or IOL. But in the late 1980s, there were no IOL manufacturers in India. Lenses had to be imported from the West.
Dr. V said, I feel guilty that I am providing intraocular lens to the paying patient and I am not providing intraocular lens to the free patient. Just because the cost of imported intraocular lens costs $200. We should make intraocular lens for $10 so that we can give intraocular lens to everybody.
With no prior manufacturing experience, Aravind set itself the challenge of producing high-quality, affordable IOLs. In 1992, they opened a manufacturing facility that produced state-of-the-art IOLs and made them available for $10 a piece. Initially set up to produce intraocular lenses, Aurolab now also manufactures a wide range of high-quality ophthalmic pharmaceuticals, sutures, instruments, and equipment.
A lot of drugs which were of no commercial interest to big pharma companies because there wasn't a big enough market, especially in the West. We got into them because there was a huge need in India and other developing countries.
Today, Aurolab is a self-sustaining, vigorously profitable enterprise. It produces over 200 products, including 2 million lenses a year, that are exported to over 130 countries around the world.
Dr. V, along with the founding team, have ingrained this thought that if somebody is blind in the world, it's the problem of this organization.
A global mission requires extensive collaboration. It primed Aravind to see allies in its competition. Today, the Lions Aravind Institute for Community Ophthalmology shares Aravind's best practices with hundreds of eye care providers all over India and in 50 other countries.
I feel like I'm part of Aravind. Aravind means a group of people fighting against needless blindness.
We give away completely whatever we do, from software to formats to patient flow, the processes and our financials, whatever specifics they need, we quite willingly share because this is for a public good and for a public work.
One recent example comes from Mexico.
Sala Uno is a social enterprise and we are replicating the model of Aravind in Mexico City. The founders of Sala Uno, they contacted Aravind, came here, studied the model and started to create a business model in Mexico. So far we have provided 12,000 cataract surgeries and Aravind is just telling us what they have done well. They share the numbers, they share their strategies, and I feel that's the right way to do it. Because when it comes to healthcare, it's a right. It's a human right.
There are three things which Arvind has been able to combine, which are very difficult and very rare to find together. One is the highest quality and excellence. One is the large number and the scale. And the third is the cost effectiveness. I believe that Arvind has been able to do this because of the spiritual foundation on which Dr. V created the entire Arvind initiative. This cannot be done purely at the level of the planning or having a high management degree or a great skill. It is, as he said, a thing of consciousness.
அவங்க நல்லா பார்த்தாங்க சரி நல்ல முறையாக நம்மளே நல்லா பார்த்து நல்ல முறையாக இந்த நாளாக போட்டாக்க புரியாத பாடுபட முடியல அப்படின்னு சந்தோஷம் தானே பாடுபட்டா சந்தோஷம்.
Dr. V's mission of eliminating needless blindness has not been completed. I'm not even sure whether it will ever be completed. It's the journey, it's the constant aspiration to be able to reach every individual. And every act of yours, can you make it a little better? That thought process is what Dr. V has seeded in each one of us.
When you use this word Aravind in the community today after 40 years of its starting, they correlate to somebody who has removed the darkness from us.
It gives me great pleasure to have Dr. Arvind among us. I would like to invite him to share a few insights. Thank you, sir.
Thank you. Good morning, everyone. It's indeed a great privilege to be in one of the premier institutes in the country. So I'm sure some of you have heard about the Arvind story earlier. I don't want to go and repeat what you've already seen in the video. So the take I will do today is what went through the founding member, what went through his head when he created this organization, and the people around him, what did they experience and how did they do this. This is a 44-decade journey, was founded in 1976. So that's the journey. You know the Aravind Eye Hospital, you know the story. I may repeat some of that, but in the interest of telling the story about how this was started and how it took. Because how things are done are very different from place to place. That will always change. The timing will have a context, the geography will have a context, but why it's done will never change. Because why has to, that conviction comes from why. Somebody does not become good because they know how to do things. Then the longevity or endurance comes from the conviction that they have a purpose behind why they do these things. So you know the scourge of blindness, right? 39 million people who are blind and 12 million in India. Indians get blind a little earlier than a Caucasian population, various reasons. We are a tropical country, malnutrition over generations, all these contribute to earlier cataract, and people are now living longer. So you have diseases related to aging, diabetic retinopathy, glaucoma, and these kind of issues are cropping up. The good news is 80% of the blindness is curable. Again, this will change because of the the diseases that come due to aging, because some of those conditions, like if you go to US, they would say 60% of our blindness is curable, 40% is not. So they have kind of going into a managing the situation, like diabetes, hypertension. Nobody talks about cure there. Everybody talks about how do I contain non-communicable diseases, how do I prevent it from happening. Once it happens, it is about managing the condition more effectively over a longer period of time. So that's true with the eye care as well. So the good news is there is a 10-minute surgery. Cataract surgery is a very interesting surgery. This is the #1 surgery globally done for any condition. All over the world, about 35 million cataract surgeries are done every year. So I'll give you an example. If you take the pensioner healthcare in this country, and if you take the age group from 60 to 65 or 60 to 70, 50% of all the money goes into cataract surgery. 20% of entire healthcare budget of US goes into one surgery, which is cataract. So it's a very significant money spinner for all the industries, all the pharmaceutical industries, all the hospitals, kind of the cash cow of eye care, and also for other pharmaceutical industries and other things. But the challenge is, in spite of it being a cash cow, in spite of it being a very standardized surgery, still millions of people we have not reached and have given them back their vision. The other interesting thing is spectacles. Spectacles is very interesting because it's estimated that at least 20% of the people who need vision need just a pair of glasses. Today there are more mobile phones than people wearing glasses. So it's kind of a very interesting dichotomy. It's a supply chain issue, not an issue of need. People need vision even to see their mobile phone better. So eye care providers have failed where mobile phones providers have really won the game and really have taken it forward. It's estimated in a country like India, we are a young country, right? We are a young country with about average age of 25, 26 there. But we are also a very old country. People kind of get carried away with this young tag. If you put all the people above 60 in this country, there are about 140 million people. We are about close to 12%. You will be the 8th largest country in the world. So it's a very significant geriatric group that we have, which has its own ramifications. After 60, if you really say, they spend more on medicine than food. So the food component keeps coming down in their household, the medicine component keeps expanding. They say 30% of entire household expenditure from 60 to 70 happens to medicine, through buying medicines and taking care of health. 70 to 80, it goes up to 45 to 50%. The last 2 years of the life, 80 to 85 or somewhere, you kind of take 50% of your entire wealth that you have accumulated over your lifetime is spent in the last 2 years because of all the challenges. Death, end of life happens by 3 ways. I'm kind of bringing some healthcare and then talking about urban. End of life happens by 3 ways. One is a sudden drop. You heard about it. Oh, he was fine yesterday. He was watching TV and he died. I just gave him a cup of coffee. He just fell down and he didn't get up. That happens to only 5% of the people. That's why we are all shocked when we hear something like that. The other 20% is a kind of a steep decline. He was fine, sir. In 3-4 weeks, 5 weeks, 6 weeks, they just decline. One after the other, there is crisis after the crisis, and then they die. The third thing, which is about 60% of the people, they always reach a new plateau. He had a heart problem, operated, another plateau. Oh, they discovered a cancer, another plateau, then chemotherapy, another plateau. So this becomes a very challenging healthcare dynamic. It's challenging emotionally for the people who take care of them. It's challenging for people who could, because the family, imagine somebody is at 75 or 80, both their children are in US or somewhere else in the world. And it's very difficult for them. In fact, it is a blessing if somebody dies like that. It's a blessing for the person who dies. It's a blessing for the family. Even the steep curve is good. 3-4 weeks, we are all able to somewhere do crisis firefighting and get things done. But if it kind of happens over years, you kind of have to really think very differently. Then caregiving, which brother is going to come and take care of them, which sister is going to come and which daughter is going to come and take care of them. There are a lot of challenges that comes with that kind of a path towards end of life. So in eye care, the reason I said we are a young country is, if you are a young country, only about 25 to 30% of the people will need eye care every year. If you go to say Germany or if you go to UK, 55 to 60% of the people will need eye care. When I say eye care, one examination a year. I'm not talking about interventions, one examination. Imagine in this country, one examination a year is about 250 million people needing eye care. every year. The numbers are huge because we are a huge country. So in India, it's estimated that if you take that population, we are not reaching more than about 30-40 million people, 50 million people today. So the need is very, very, very high when compared to the service that we are catering at this moment. So this is he is our founder, Dr. Venkataswamy, and he had this vision to eliminate needless blindness by providing compassionate and high quality care. The challenge that he threw at all of them, himself and then the organization, is affordable eye care to all. Look back at 1976 when your per capita income was about $120. And at that point of time, we will be surprised, China's per capita income was less than ours. They did something in the last 30-40 years which we have missed, and we are where we are and they are there. So at that $120, $130 per capita, you are having 80% of the population who can't pay anything. Or little, very, very frugal living was their conditions. So they had very little money. So imagine Dr. V had this great vision in 1976 and he said, I need to give to eye care to all. So at that point of time, 20% of the patients were willing to pay, or they had the money to pay. The other 80% did not have. So that's the ecosystem that created a lot of what you will see unfolding in the next 4 decades. Because that kind of got ingrained into the DNA. We need to reach out. And it became better as the days went by, right? It's not $120 today. It's $2,000 odd today. So as the economy, the whole pyramid is moving. Though we have a bottom of the pyramid, the whole pyramid is going up, which was $120 at the bottom. It's today at $2,000 at where it is. So these are different elements of Aravind Eye Care System. You kind of got a glimpse of all these things in the video. And all of these things came not because of a strategic thinking of we are going to build an institution. It came because they wanted to nurture an ability and nurture a team that can sustain itself over a period of time to deliver better eye care. And as the organization grew in scale, it was also important to build a lot of backward integration to be able to meet the demands that came from growth of an organization. Started with 11 beds in the year 1976, as I mentioned. Today we are in multiple locations, and we examine about 13,000 patients a day, perform 1,500 surgeries, and we are also one of the largest postgraduate training center in the country. These are the different physical locations. We cover Tamil Nadu, parts of Andhra and parts of Kerala. About 100 million people is our zone of coverage. In that 100 million population, we provide 45% of all eye care. So our challenge is not today dealing with cataract or, because cataract is lucrative, so a lot of people are interested. Eye care has 2 elements to it. One is the one-time intervention, which is cataract, refractive surgery, simple surgeries, contact lens, cosmetic surgeries. All of that is a one-time intervention. So people say, wow, they will have that wow effect, and then they go back. They're willing to pay a lot more than what is needed. So there is a surplus that you can generate. The other side of the coin is this chronic conditions. You know, a diabetic retinopathy will come every 3 months or every 4 months, and you'll have to see them just to keep them where they are. Everybody says, I know, just like blood sugar, right? They say my blood sugar is normal, and just to keep it normal, we all have to work hard. The patient has to work hard. You're not trying to do anything, any rocket science business there. Very simple, just keep them. So the challenge for us is, how do you deal with that? Because it's a very trickling revenue, time consuming, and you don't have that kind of a cash flow to be able to sustain. So you have to build a cross-subsidizing model within the organization. So your cash cow is a one-time intervention. There you compete with everybody in the ecosystem. There is a private practitioner, there is another institution. You compete, and then you kind of cross-subsidize the second element. So this is what Aravind did in the last year, 4.1 million outpatients and 478,000 surgeries. And this is over the years. We have done more than 6 million surgeries. So there is another cross-subsidizing model here, which is the ability to pay and people who did not have the ability to pay. So Aravind Eye Hospital has 3 channels of entry for their patients. One is the paying channel, which is a conventional channel. This is like anywhere. You go to get an eye care with any other provider, Aravind is one more provider. The second channel is a free hospital. In every hospital, every facility, physical facility, there is a free hospital where you can walk in and nobody is going to question why you are walking into that facility. Nobody is going to judge whether your ability to pay or not. This is a learning that we got over the years, because we realized, one, you breed corruption when you start intervening. People try to take off their jewels, people try to wear old clothes, that's at one end. Second, your own staff take advantage of the system. They try to bring in people who could afford, who could not. So we said we will keep it open, let the society decide or the community decide who wants to get it. What we have found over 40 years is people always ask us, do people exploit you? I've never seen them exploiting. They exploit, yeah, about 10% of the people exploit. But the other way is also true. 10% of the people who don't have the money will sell something and then come to the paying hospital. Because they feel I should give my best to my mother, I should give my best to my father, let me sell this land or cattle and I will give the money. So we have always found that very interesting. Somewhere the community finds a balance and there is a very interesting mechanism of lack of exploitation. We all do that, when we travel, there is somebody going in a first class, somebody going in a business class, economy. None of us feel bad about traveling economy, or though we would a little jealous about the people who are traveling first class and business class, but we are fine with that because we know the destination is the same. There is no difference in the destination. A little better food is okay, I guess. So that's where the second cross-subsidizing model came into existence. So the important aspect at Aravind is the cost. Again, when you compare the cost of delivering eye care in UK, it's roughly about say 1.6 billion pounds. This is not unimaginable because UK over a period of time, UK, US, all the developed countries has built a healthcare system which is not sustainable in the longer run. It is not even sustainable for a $50,000 per capita income. So if we start aping that model of based on 50,000 where they are finding it difficult, if we start behaving as if that is a gold standard, with $2,000 per capita income, when are we going to give eye care or health care to any one of our people? So we will fall flat. So I think it is important for us to, Dr. V realized it way back. He said our constraints are our strength. Because our constraints are there, we are able to think very differently because we don't have a choice. In America or Europe, you had a lot of choice. You had more money to put on a small fire. You had a larger carpet, thicker carpet to push all your dust in. So there was no incentive to be efficient. But that incentive came from the strong purpose that the individual had. Because that's a very, very important turning point in any organization. That's why you see Indian cricket team, with one cricket team captain it fails. The same team in another captain, it seems to be a miraculously winning team. So what happens with that one person coming into the team seems to be a very important chemistry that happens and changes the dynamics of how things work. So this is the question that we are trying to address today in this discussion is, what made Aravind to build a frugal approach to healthcare? I have given you the context because of the per capita and all that. I think Dr. V, as a person, I would say if you really ask me what made all the difference, it's one individual. All the rest is, we can ignore everything else. That is all how you do it. But what was the most important person is someone at the age of 58 looked up and said, from a very, very average family, and if you really look at his platform, where he started, very average platform. His family, his father was an agriculturist. His wife, they both were doing agriculture, and then he had about 5 siblings and 8 siblings, and 3 of them died early. That was a kind of the norm at that point of time. You had more children because you know you're going to lose a few in the first 5 years. So that's how they came into existence. And his education, he went into law school, then he decided he wanted to be a doctor. He went into being a medical doctor. Something happened. He went into defense. He joined the army way back in 1940. And after 5 years, he was discharged because he had psoriatic arthritis. If you can see his fingers, it's very crippled. All this is because of psoriatic arthritis. Psoriasis, right? It's a skin lesion, and skin lesion along with an arthritis. So he was bedridden for 3 years. So that purpose does not come, that compassion comes because you have suffered. You have endured that. You have been pushed by people around. You are not able to use you're not able to go to the toilet by yourself. You're not able to do anything by yourself. Imagine an individual at that stage of life, young, vibrant individual at the age of 27, 28, bedridden, getting humiliated, holding on to your pride. A lot of it is getting internalized and getting synthesized. I think a lot of conviction came from that element of having compassion and also empathy to others' suffering. That empathy is probably what has led him have the conviction to build an organization that will continue to do what it did. The other important aspect is very few people own a problem, right? None of us, all of us here, I'm kind of generalizing, We all find a lot of problems that we come across. The city is not clean, something is not good. We have problems. But rarely we have the conviction and say, I'm going to give my life to solve that problem. So this individual, he was an eye doctor, retired from the government at the age of 58. Somewhere he owned the problem, because nobody loaded the problem to him. He just came in and said, this is my problem, I need to solve it. And there are situations like that we come across. That's where I think greatness starts happening. Somebody owns up and says, I need to solve it because I feel for it. They are in the right place at the right time and the magic starts happening. And the other thing is, he was always far-sighted. He was always his ability to think beyond the constraints of that time was always very important, because you have to bring in optimism to the organization. When he started, the first few people, about 10 employees, 4 of them were from the family. Who will trust a 58-year-old individual, a retired government employee? No one else will trust him. He had this grand vision. At that time, it was not as grand as it is today, but he had a vision. And the only people who trusted him were the people who looked up to him as a patriarch. He was a bachelor, not married, but he was the one who brought his siblings. And that was very important. So there was a bond which was very strong. The second aspect in him is the spirituality. The Aurobindo name comes from Sri Aurobindo of Pondicherry. You would have heard about him, Sri Aurobindo and mother. So he went to the ashram, he was a member of the ashram. So look at it, empathy had a grounding, spirituality had a grounding. All these gave him, because a lot of times when you build an organization, you are constantly under threat of new ideas, threat of I should drop this and do something else. Today's world, they have another word for it, right? Flipping or something, they call it. The new business, they say if it doesn't work, I need to change. But if you really want to do big things and great things, you don't change. The why is very constant. You don't change because the tide is changing. Sometimes the tide is in our favor, most of the times it is not. But when you have the conviction to do what it is, that's what I've seen in Aurobindo. When the tide comes, you really are ready to take it and you really go very far. And then for the next 10 years, you're kind of standing where you are. You're swimming as hard as you are, but you're not going anywhere back or front. The other important aspect is a lot of selfless service, and he was a leader by example. He was a very simple man, came into the organization at 7 a.m. and he kind of led. He was not this person who was kind of very charismatic or very articulate. He was a very ordinary man, but had a deep conviction. We've all been with people like that. A teacher would have inspired us a lot more than a person with tremendous power, because that quiet conviction has a deeper reach than a loud conversation, I guess. And the other important aspect is, sharing and building capacity. I somehow feel the age at which he started was a very important age. 58 is a very interesting age, because at 58 you are not a player anymore. If it's cricket, at 35 you are not a player anymore. You're old for that game if you're 35 or 36. So you kind of come in as a coach. Your ability, your constant energy is going into developing others' capacity. I think that was a very interesting combination that happened in the organization in 1976 or to 80. Here was this gentleman at 56, 58 who was retired, and he knew the game. He knew how to do eye surgery. He had built the network and the platform, right? One of it is family, I said. Second is net worth, the money that we all have. Second is the network, the connections that we all have. Fourth is the health. If the health is not good, it's very difficult to leverage the platform and do something. He did not have the net worth, but he had the network. So that network kind of helped him to address and start building individual capacity. So people kind of saw him as this person who is going to make me better than who I am. So he kind of became a magnet. People came, like Gopi Chand in India. Suddenly Gopi Chand comes and all our players are winning Olympic medals. Where were they 20 years ago, 30 years ago? So one individual had the conviction that this country has players who can compete at the level of anywhere in the world. And we are able to see the reflection of that. And suddenly you start seeing magic happening. I was reading a newspaper and said Saina Nehwal got a 100 crore contract for advertising. That's the magic happening. It's not the game. But suddenly aspiration starts kicking in. Can my child get in there? Not the money. Money is not the first thing that comes into their mind. They know there is a potential. There is a lottery that my child can win if they can play at that level. So suddenly the whole ecosystem is changing and a lot more players. And that's what happened in eye care. We kept seeing more players coming into this team and really championing and challenging the status quo. We were not at the receiving end, but we said anywhere in the world we can go and talk about what we do, how we do, and stand with conviction that this is the right way to do. And not get carried away or not get cowed down by somebody coming from another ecosystem telling us, oh, this is not how we do. What are the challenges faced by the founding team and the core team? This is the challenge, right? Anytime anybody tries to do something new, out of the ordinary, all of them will have this problem, right? There is no proven model to follow. You have to fall down and get up and fall down and get up. And magnitude of the problem versus resource scarcity, look back at 76 or 80, the problem was much more. And people would be very fine saying that, what could he do? A retired man, an individual, what could he? All of us are, it's a great story to say, this man tried hard, but he did his best and he moved on. But rarely people say, oh, he didn't move on. He stayed put, and sometimes magic happened and life took him to where he is now. By the way, he passed away about 13 years ago. And I'm speaking as if he is there. That's the impact he has on the organization. And people like them they don't pass away. The stories keep repeating. It gets better actually, like old wine. And rituals keep happening. And that's how you kind of, Professor Ravi Mathai in IIM. Every time I come here, I keep hearing about him. He designed this building, he saw that. I was in ISB, and then they spoke about how ISB was conceived and how things happened and all that. So sustainability and age at which I had covered earlier. So these are the three building blocks which we saw looking back at the organization. A lot of these insights came from people studying the organization. So one is a strong value system which I shared with you, give eye care to all. And Dr. B was also very fond of, very forward-looking and also very ridiculous in some ways. He said, we should learn a lot from McDonald's and Burger King. These guys know how to open restaurants and everywhere in the world. They're able to standardize food. Entry level, a class dropout, a school dropout is able to serve burger. Wherever in the world people go there. So he says if we can use those principles, clean toilets in those places, why can't we use those principles to do eye care? So that was his premise, and then how he went about doing it. And if you had to marry these two, give it free, but also give it at a standardized care, then only way was to bring in innovation and you're able to do things differently. So I'll let Dr. V speak to you on the value system.
I used to sit with the ordinary village man because I am from a village. And suddenly he turned around, and then you seem to contact his inner being. You seem to be one with him. But here is a soul which has got all the simplicity of confidence. Doctor, whatever you say, I accept it. An implicit faith in you. And then you respond it. Here is an old lady who has got so much of faith in me. I must do my best for her. When we grow in spiritual consciousness, we identify ourselves with all that is in the world. So there is no exploitation. It is ourselves we are helping. It is ourselves we are healing.
I think it's a very, very powerful concept, right? A lot of us don't realize when you do something good to others, it's ourselves we are helping. Imagine in this room, all of us probably belong to the top 1% or 2% of this country. Have a tremendous, you're able to sit in this chair in this institution, you're in that kind of a platform. Otherwise, you wouldn't be sitting here today and we wouldn't have this conversation. And with that kind of a platform, it becomes our responsibility because 99% in the bottom is holding us where we are. Somebody made a very interesting observation. They said, the plane is flying there not because of the pilot flying it. There are 100,000 people on the ground making it fly up there. Same thing is true for all our lives. The food that somebody is going to provide for lunch. Somebody has had an agriculture business to create that. So a lot of people are sustaining this ecosystem to be where we are. So when you're at the top, we have to be very, very clear that we nurture down. Let's be selfish. Nurture it for our own children and grandchildren, but we have to nurture. If we don't nurture, we are kind of digging our own grave very clearly. So that's what Dr. V saw, when he kind of looked at that old lady and said, this lady has so much faith in me. Can I do the best for that person? And then that starts the journey. Doing the best immaterial, whether they can pay or not. Then you are very differently thinking. And then the world is also aligning with you. Arvind is not a story of 5 people building an organization. A lot of people from US, a lot of people from Europe, multiple people have come. It's an open platform, right? When you have an idea of that large an idea, the whole world is interested. People are interested in being part of something which is revolutionary and changing. So Arvind kind of became a platform where a lot of people contributed. So So this was kind of the situation in India, right? Maybe some of it is also true today. We are not as dispersed as Africa. Now we have opened recently a hospital in Abuja, Nigeria. Nigeria is a little better. But if you go to countries like Ethiopia, Kenya, it's so so scattered a population, become very difficult to put your hub and spoke model. Hub and spoke model, which Arvind is very, very good at, doesn't seem to work in a population which is spread over like that. So these are challenges that you kind of face. What works here, as I said, how you do it will keep on changing and evolving with times. And very interesting, on the how, we are now seeing a situation, the need for free hospital is coming down drastically. Ayushman Bharat suddenly comes and says 30 crore of this population is getting insured overnight. And suddenly where is the poor? The poor have access to resources. It might not be their own resource, but someone else is paying the premium for their resource. The government is paying the premium. So you suddenly start seeing very different dynamics. People become consumers. People start demanding things. So that equation kind of becomes very interesting. That's what we see. It changes the economics of the organization. You suddenly have 90% of the people who could pay. Then our ability to think and execute becomes better. But holding on to the conviction, unless you don't want to get all that resources and gain fat in the organization, you have to keep yourself lean to try to accomplish what needs to be done. So most of what we have done at Arvind starting from 76 was consistently designed for non-customers or non-consumers, because the non-consumers outweigh consuming population in healthcare in this country. Take joint replacement, take cardiac care, anything for that matter. Every sphere, I would say we are probably, I may exaggerate, probably doing 5 to 10% of what needs to be done. And that's where we are in this country. And that dynamic may change because of all this insurance and everything that is coming. But I don't know whether we have the capacity today. If all of them seek eye care, all the ophthalmologists have to run away, because they will be swarmed. It will be a tsunami of demand that comes and hits us. So we don't have a lot of time. Our people need it. Many of us in this room, they say 50% of this population at the age of 65, 70 will need at least one joint to be replaced. So we are all customers. Hope in 20 years there will be enough healthcare facilities to cater to all that. And one of the ways that we reach to the non-customer is the eye camps, outreach programs. All of you are familiar with this. The accessibility is the major critical issue in healthcare today. They don't want to come from a village, very difficult for them to come. So you go and surface the problem and bring the patient to the hospital and do the surgery. We also did a study about close to 20 years ago, is how effective these eye camps are. To a surprise, and it's also logical, eye camps can work with only diseases that can wait. Eye camps cannot work for diseases that cannot wait. Imagine if somebody has a myocardial infarction or a stroke. You can't say, I'll come after 3 months for an eye camp or a health camp and we will deal with that. Right? It's not possible. So we need to deal with it then and there. So we realized that's very important, and we kind of explored a model called Vision Center. It's very challenging. You know, the models are sounding good. Our challenge here is we are not able to get staff to go to the rural area and work, like all the healthcare problem, right? That's why Ayush doctors want to be integrated into medical practice. So we don't, even our own nurses, these are manned by technicians. We are not able to get technicians, and genuine problems. I want to put my child to a good school. My spouse does not have a job in the rural setting. I need to be in a semi-urban setting at least to be able to have gainful employment for my spouse and myself. So though we are covering about a 5 million population, in our own target area of 100 million, we are only able to cover 5 million. Not because we don't have resources. Our challenge is the human resource. So stretching scarce resource is a very important model. You saw in the video as well. All of what Arvind has done on the operation side came from this. Can we make that 1 rupee run longer than it is? That has been kind of the DNA of how this got evolved. So simple thing, right? Technically, if you go to a US-like setting or a developed country, you will have 1 surgeon, 1 surgical table, 1 scrub nurse, 1 instrument. They may do 1, 2, 3 surgeries per hour. There are some surgeons in US do 15 surgeries an hour, but they are the exceptions, top 1% of the country. But average surgeon in US, maybe this is true in India too. So with simple changes, 1 surgeon, 2 surgical tables, 2 scrub nurse, 6 instrument sets, the same surgeon becomes 6 to 8 times more productive. So if you can surface the demand, because this surgeries does not happen, because if you really ask me what is the biggest challenge in Arvind eye care system, it is not giving eye care, it is logistics. How do we feed 13,000 people every day? Tirupati gets 65,000 people every day. Tirupati's biggest challenge is not Lord Balaji. Tirupati's biggest challenge is security of these people, avoid stampede, feed all of them, give each of them a laddu. All of that is a bigger challenge for them. Balaji is easy. You can put CCTV, you can put multiple cameras and show it to him, live telecast. But all these experiences make Tirupati a special place, right? Same thing with us. That 13,000 or 15,000 people every day, how do we handle them well is a bigger challenge. So this is one figure. An average surgeon at Aravind does about 1,500 surgery. This is very important for us because this is a number that keeps us economically viable. And everything that we do, where logistics comes is because of that. We have to create that whole supply chain of patients. The surgeon is standing in the operating room and willing to operate, but somebody has to go to the village, surface the patient, transport them, take care of their diabetes, hypertension, bring them to the hospital, put antibiotics, feed them. They should not fall down, fracture should not happen. All these things have to be done. A lot of times, including us, we glorify the surgery part. If you ask me, surgery is the easiest part because it is done in a standard atmosphere. Everything is controlled. The water is controlled. The air condition is controlled. If something goes wrong, it goes wrong beyond your capacity. But a lot of things can go wrong in a road. A lot of things can go wrong in a food because you don't have that kind of a control or appreciation of what are all the things that are involved. The other important aspect that the organization soon learned in 1976-78, they started expanding. They said, what was the bottleneck? Doctors were a bottleneck, but not as significant as the nurses. Because that time, the nurses were only, general nursing was the only thing that was available. They all had their 3-year, 4-year general nursing. Auxiliary nursing or something is what they would be called. And they were not trained in ophthalmology. So you had to take this, and their expectations were much higher. They wanted to work in a multi-speciality hospital, they wanted to work in ICU, in a different operating theatre. So at that time, the family, Dr. Nachiyar, whom you saw in the video, one of the lady who spoke, so she said, we are all from village. There are a lot of village girls. The village boys had work because they went to the farm and all that. They were productive. But the young women, either they got married early, at the age of 16, 17 or 18. But when they were not married, the family found it very difficult to retain a 17, 18-year-old girl in a house. One, it was not a pakka house. Number two, both the husband and wife had to work to sustain the family. They had 3 or 4 children. This was not the only person. So when this idea was mooted, only about 9 girls came because they trusted that the founding members because they knew the family. And then that grew. Today we take about 1,000 to 1,100 young women who come. Today we compete. We compete with retails, we compete with textile mills, we compete with everybody because everybody has realized that group of young women are a very, very productive and a very, very smart workforce that is available. Yeah, so I have another 5 more minutes, 10 more minutes. Okay, thank you. So if you really ask me, who builds the organization, the core of the organization, it's not the doctors. I'm one of the ophthalmologists. We don't build the organization. The character and the DNA of the organization is built by these young women because patients are more comfortable dealing with these young women than doctors. With doctors, there is a resistance. Doctors also get tired and have their own limitations, as you would have all experienced. So you start wondering how did they become doctors in the first place. But you have to offset that. And then you offset it with the young women who are genuinely caring and who come from that kind of an ecosystem. They are from a rural background. They're able to provide care. So they perform most of the routine clinical tasks. So next time you go to a hospital, you go with all the good words about you and all that. Don't ask the doctors to do certain investigations. They are not good at it. Don't tell doctor, you didn't check my BP. Please, you wouldn't have checked it for the last 25 years. So someone else is better checking all that. So routine investigations is better done by somebody who has done. In fact, there is a nice story. They said, I believe one of the senior politicians went to a large hospital and a senior doctor. He said, and surgery was fixed for him. And he asked the senior doctor, doctor, I didn't see your name as a surgeon. I saw another name as a surgeon, but as a favor, you should operate me. He said, as a favor, I'm asking him to operate you. So it's easy to get carried away when you see the big names. They may not be good at what they do. So these women kind of do a lot of all the routine tasks in the hospital. The other concept that we have, again, a lot of this is marketing or people from your fraternity who have kind of told us how this has evolved and how you can look at it. So Dr. V wanted to give intraocular lens. You would have seen from the video. He felt guilty that he was not able to give intraocular lens. So that's how we got into manufacturing. A bunch of doctors sitting in late 90s or early 90s and saying, you know what, we are not able to provide the same care as to the paying patients. We need to do. So zero capacity, but aspiration to do something. The capacity keeps coming. Somebody from US called Seva Foundation. So that's where I said, when you kind of have an open platform, a lot of people come and contribute. So that's how manufacturing came into existence. And consultancy, way back in 1981, there was a team of about 20 people who came from Nepal to Arvind. And Arvind was a 20-bedded hospital at that point of time. So that ability to spawn another organization, that compassion to have, we can share something with the other people, we can genuinely be able to contribute to a larger cause. And today you go to Nepal. Nepal is one country which does more service to India in eye care than any other thing. Nepal does close to about 800,000 surgeries a year. 500,000 people who benefit are from India. So Nepal is a big contributor to our eye care system in this country. A lot of our bordering states are near Nepal. Patients would be bussed into Nepal to be able to get the care. And this is the manufacturing arm you have already seen in the video, Aurolab, and making eye care affordable. Again, once you kind of start hitting the constraints, one is the human resource constraints. You are able to bring in young women and take care of them. Doctors constraint, you are able to start a training program and bring your postgraduates, fellowship and all that. The third constraint, your consumables. Because in a healthcare setting, in a hospital setting, most of the time, 80% of your cost is fixed. You already have the building, you already have the air conditioning, you already have the people. So the variable cost is 20%. So if you have taken care of the fixed cost comfortably, the variable cost is the next element that you could attack. So that's how Arvind went into the consumable manufacturing, making intraocular lens, sutures and pharmaceutical products. Then it became a business on its own. This is a not-for-profit organization exporting to about 160 countries. So what Arvind has done is it has ensured affordability for both the patient and the community. A lot of times when we say free, it's not free for the consumer. Because to get your product, the consumer has to spend more. Give you an example. If you go to an eye camp, right? You go to an eye camp and you examine the patient and give a prescription. Say, yes, you need a glass. With this glasses, your vision will be good. Right? The patient also understands, he has tried the glass. And then you give him a piece of paper saying, this is your prescription. So he takes the piece of paper and he goes to the next town, because that small village won't have the optical shop. He goes there and he has to spend that day's wages. Somebody has to accompany him if he is older, and then go up there. Maybe he spends 100 rupees to go up there, losing job, 100 rupees. He would buy a spectacle for 300, 400 rupees. And again, he has to go back the second time to collect it. He will spend 500, 600 rupees in this whole transaction. But for that, the value of the glass will be 30, 40% of the overall value. So that kind of hit us very hard. We said somewhere we have to make it really genuinely affordable, not affordable for our own feel-good factor. It has to be genuinely comfortable for the patient to get care. And what we did early days, gave it away for free, charge market rates for those who can pay. I think the most important thing is the founder's DNA. He kind of gave it in the mindset that if you give it free, it doesn't take away anything, it adds more. That's the lesson that we have learned. And that's, you see all the big companies in the world, they give everything free. Google gives everything free. Facebook gives everything free. They seem to be the largest companies in the world. They seem to be able to leverage that kind of a volume with some other business models. I'm sure you're all more familiar with that. And Leico, again you saw that, work with different hospitals in different countries to build capacity, research institute. So finally I'll come to this point, right? This is what I was trying to expand. So people start seeing free as altruism. Free is not altruism. Free is very important. Like if the government does something like Ayushman Bharat or something that does, it's productivity to this country. It adds to the GDP. And I'll give you a story, right? In Tamil Nadu, they did a study. And this was a study done about our past Chief Minister, Madam Jayalalitha. Very populist. She had a lot of populist programs in the country, in the state. And she gave a lot of grinders for the women. Grinders and, what are the other one? Mixers. Grinders and mixers. She gave one of the elections. And it was obviously it was a populist. She wanted to win the election. Somebody did a study very interestingly. And they kind of presented the study. It saved for every household women, it saved 2 hours of their day. It was physical labor. Most of these women were anemic. they were able to save on the physical labor, they were able to take care of their children better. So the unexpected benefits outweigh all the populism that goes. So that was a very revealing lesson. So for us, what does the free do? Free gives community acceptance. I stand here not because of the paying surgeries that we do. I stand here because we are a community player. That's why you would be listening, and the scale of what we do comes purely from community acceptance. Scale again comes from there. Again, if you're dealing with that kind of a volume, you have to build an efficient model. Right? Efficiency is important. Frugality, if people can't pay anything, you will have to build a model that is very frugal. And then training. And the paying also gives you something, right? It does not orphan you. It gives you a financial surplus, focuses on outcomes. Paying patients have choices, right? They can go anywhere. And then also, as people want better service quality, and gives access to technology. So this combination is very special. So this yin-yang combination is very difficult for anyone else to replicate. Because that's why you find people only doing this. That's why it's very difficult to replicate a Toyota. It's very difficult to get that kind of a milieu, because they're able to see the benefits of doing low cost with a high quality. And it's a very potential combination. So let me kind of conclude my talk with Dr. V's favorite quote: intelligence and capabilities are not enough, there must be a joy of doing something beautiful. Thank you.